por problemas de salud nos ha dicho que no va a poder estar aquí. Ya sé que si nos aplicamos las zonas de regulación emocional, en este momento seguramente estamos en la zona roja, ¿no? Que es cuando nos lo comunicaron a nosotros, ¿no? Pero luego, bueno, como personas que somos, cuando nosotros nos piden un deseo, que pensemos en un deseo, ¿qué deseo pensamos? El primero que nos viene en la cabeza, estar bien de salud, ¿no? Pues yo sé que Jonathan Green es una persona súper formal y que realmente si no está aquí es porque no ha podido venir, porque realmente tiene un problema de salud y le han aconsejado en el que no pueda estar aquí con nosotros, pero bueno, seguro que tendremos otras oportunidades para poder compartirlo presencialmente aquí, ¿de acuerdo? Voy a ir rápida en la presentación porque vamos un poco justos de tiempo. Jonathan Green es profesor de psiquiatría infantil y adolescente en la Universidad de Manchester y además forma parte también del Centro de Investigación Biomédica de la misma universidad. Se ha formado en las universidades más prestigiosas de Inglaterra. En Cambridge hizo la carrera de medicina y luego en Oxford la especialidad de psiquiatría infantil. Además es miembro y consejero y asesor de muchas revistas, pues revistas de psicología y de psiquiatría infantil, es miembro del INSAR. Y desde hace mucho tiempo yo pienso que su interés clínico y de investigación ha sido sobre el autismo y aspectos del desarrollo sociocomunicativo. Desde el punto de vista clínico, él dirige una clínica especializada en desarrollo social en el Royal Manchester Children's, donde lleva a cabo tanto lo que es la investigación, la valoración e intervención en niños con TEA y otros problemas del desarrollo social. Y sobre todo yo pienso que a él lo conocemos por autor del programa PACT, junto con Catherine Aldred. Y además tuvimos la suerte de tener a Catherine Aldred en el anterior congreso en Murcia, que pudimos hacer pues, el curso de formación de PAC. Y actualmente pues, hay más de 800 ya profesionales capacitados en 24 países en este programa. Y yo pienso que además PAC representa lo que sería la esencia del programa de empoderamiento familiar, ¿no? Que yo pienso que como profesionales y cuando ya llevamos mucho tiempo pues, formándonos en diferentes programas, pienso que tienes que coger la esencia del programa y saber aplicarlo en el empoderamiento tanto familiar como en otros contextos comunitarios, ¿no? Y ya, sin más, y si todo nos funciona bien, os dejo con Jonathan. Y el tema de la ponencia de hoy es estado de la ciencia respecto a la intervención en TEA, evidencia e impacto en la vida de las personas.
Hello everyone, I'm sorry I can't be here with you in person, but it's very nice to talk to you about the presentation that I was going to give you live in Madrid. So this is a new approach to early support for autistic trajectories and neurodivergence, which I want to introduce to you and give you an example of two interventions that I've been working on for between 10 and 20 years now with colleagues, the I-BASIS and the PACT interventions. So what are the principles behind these interventions? The first is to say that autism is a developmental and enduring condition. We know this, but much about our current intervention practice does not reflect this knowledge. The second principle is that social competency, social engagement in the community is a key value for any human being including an autistic person, and that this is the first focus for the work that we do. The third principle is that our current intervention practice does not really address these needs very well. It's generally reactive, and it has, in general terms, the evidence, the interventions that is done across the world for autism has a very poor basis in evidence for effectiveness. It comes on too late in the condition, developmentally, and it doesn't address well these core developmental issues. Because autism is such an important condition for us in the community and in our concerns, it is really a scandal that we have this situation where so much money is spent on so many interventions without a good evidence base. So I hope to show you today the kind of evidence that we can produce for interventions working and how that might be a basis for an intervention care pathway. So what we need is interventions that are efficient, that are based in evidence, and that are developmentally focused and sequenced for the autistic child and family in early development. So the route we take towards intervention with those principles is a route that works with families, with parents of children, to improve their understanding and resilience as the primary caregiver of their child. And this is an intervention developed to help parents who have children with neurodifferences and early autistic trajectories. And I'm going to talk to you about the iBasis intervention for infants, very young children, who have early developmental differences that make their likelihood of developing autism increased. And then I'm going to talk to you about the PACT intervention, which is an intervention of the same kind, which is directed at children who have a diagnosis already. In this intervention, we work with parents, and I'm going to talk to you more about that. We don't work directly with the children at all, but we work with parents to help them understand and respond to their child's communication. And then on the basis of that and developmental understanding, we think that the child will then change their behavior in relation to the parent. And then based also on developmental understanding, we hope that the child will generalize the changes in the dyad with the parent out into their everyday lives. So that there is this three-step approach in the intervention that I'm going to demonstrate to you of how this works. The theory base behind these interventions comes from neurotypical developmental theory, the importance in many ways of early interaction, naturalistic interaction between parents and their children to facilitate the growth of their child's competency in social life, but also in terms of their relationships, their self-confidence, their motivation, and their mental well-being. And we know much about this from ordinary development. And we know that the attunement, the interaction effectiveness between the child and the parent is a key to these good outcomes. So the question is, how does this work when you have a child who has neurodifferences, and difficulties in early social communication. How does this difference affect the interaction with the child, and how might that make a difference to the outcomes? And we've made studies of these in basic developmental science to look at the interaction effects of early neurodifference. We've worked in the first year with babies at higher likelihood of developing autism because they are siblings of children who already have the condition. And we've shown that by about 7 months, we see subtle differences in the nature of the interaction and the way that parents are able to respond and communicate with the baby. This is nothing to do with parents being having a problem in their parenting. It's to do with the difficulties in the parent understanding the child's communication. And we see that the parents respond to this with a sense of what we call directiveness, often, to try and teach and help and structure the child in a very active way. And this is different from the way that, in general terms, parents work with children. So we see these group differences starting from about 7 months. And then we see from about 14 months, differences in the way that the babies respond to the parent. These differences in the parent continue at 14 months, but the differences emerge in the way the baby responds to the parent. And it's these differences that in the social interaction and response of the baby to the parent that predict later autism at 3 years. So this is the change. So what we are interested in our interventions then is to make an intervention in the interaction, in the dyadic interaction, that tries to move this more towards a developmentally positive process that can improve all these downstream outcomes for the child on the autistic trajectory, improve their social communication, their psychological health and well-being, and their interaction capacity. So what is particular about this form of intervention? It works and is focused with the parent in their naturalistic interaction. Why do we do this? Because this is the way that children learn communication and sociability in real life. And if we can put this kind of intervention in that family setting, then we change things for the child 24/7. It's also very efficient for professional time because we work with the parents to make them the key expert in helping their child over time. This does not mean there's anything wrong with the parenting. It means that we engage with the parents in collaboration to make them the expert in their child, so that it makes the families resilient. And the way we have to do this, because this is quite a technical procedure, the parents have really to learn important lessons here. They have to develop skills. And we do this through video feedback, which is the most efficient way that we think we can get this kind of adult understanding. And you'll see how this works. So in this form of intervention, we take videos of the parent with the child, and we play the videos back to the parent with the therapist. So let me give you a demonstration.
Exciting. Stop. Oh, yes. Together. Push. Stop. Nathan, stop. You say Pico. Pico. Where's he going? You found
So this piece of video is then played back to the parent with the therapist there in the room, as you'll see.
The one where he understands Nathan. Yeah, and he got quite excited when I stopped it. Yes, the first time you put the stop in. I think that's right at the very beginning. And that's something that's really quite interactive because I think he realised I did that and it made the game more fun. Yeah. Well, let's watch that bit again and see, just see what it is. Let's have a think about what made it interactive. What were you doing? What was he doing? What signals was he giving you? Yeah. So that to
That's what I need to read.
This means he wants me to be in this bit. Yeah.
So you'll see here that we work with the parents to help their exploration. They explore the video themselves and make their own meaning with the help of the therapist so that they're making a discovery about their child. And this kind of active learning, watching videotape, is an excellent way of helping parents get insight into the way their child works and the way that they interact with their child. So the important thing to say first off about this method of work is that we have good evidence that it is effective. So this is the evidence base for this work is the only reason that I can really stand up here and suggest to you that this is a good way to go for autism intervention. So we have 7 randomized controlled trials to show that when we work with parents in this way, we get the change that we expect in the child's interaction. So we can improve the parent's what we call synchrony and responsiveness to the child. And we show that as a result of that, the child improves their communication with the parent. And remember, we don't work in this form of intervention directly with the child at all as therapists. We work only with the parent. We then have 4 randomized controlled trials that have replicated the fact that when we get the change in the child here, this then generalizes out into the child's functioning outside the family with other people. This is the key moment of generalization. If we can't do this with a therapy, in my view, we're not really improving autistic life and trajectories. Many therapies just show change here, which is a good thing, but what we really need is to improve the child's development in their everyday life. So this generalization, as we call it, is crucial. And we have replicated effects in 4 randomized trials that we do this. We have one trial in which we did not succeed in this, and this was a trial in which we did a lot of intervention in schools, which proved much more difficult. So this is not automatic. You need to have the right conditions in place for the therapy for this generalization to happen. And we had one other trial where the result, it was a small trial in India, and the result was a bit equivocal. The next phase then is to show that this change in the child's everyday life in the community persists over time. In other words, we have made a developmental change for the child that doesn't just wash away over a short time, but is sustained. And this then is the key test of whether we have a developmentally effective intervention. And what we've shown in 3 randomized trials, these are the most important trials that we have published, is that this change we show has sustained itself for between 3 and 6 years after the end of intervention. And we show a treatment effect existing over all that time. And I'll show you the details of this in a bit. The fact that we can show in 3 replications that we can do this gives me confidence that this model of therapy is useful for developmental services in autism. So let me tell you now then about the first of these interventions, the iBasis for babies. And in this intervention, it's a 5-month, 12-session intervention which is conducted by the therapist at home with the, let me put this on here. Sorry, with the mother or the parent. And we use this video feedback technique, which I've showed you. And the sequence of sessions is developmentally sequenced to follow the sequence of normal development of social life, relationship, and communication, from parent observation of their child to the understanding their child's communication, which is sometimes difficult to understand in early autism, and then building on this to help their emotional communication and their social and language communication. And we have specific adaptations that we use for the atypicalities that emerge in development. So let me show you the kind of effects we want to achieve in improving parent-child interaction in this form of therapy. So here is a 7-month baby with his mother at the beginning, before the therapy begins. And you'll see that the mother is directing the child, trying to show the child what to do, working hard. And the child rather passive, following the parent, not terribly well engaged. At the end of therapy, we want to have something more like this. So the parent and the baby are more engaged, they're looking at each other, and you'll see that the mother is following what the baby does, mirroring it, building on it, and they develop this mutual enjoyment together and interaction, and mother then plays a social game. And this is the interaction context of attunement in which social learning happens, both in neurotypical babies, but also we show in neurodivergent autistic trajectory babies as well. So what are the results we get from the randomized controlled trials that we do with this kind of intervention? So the first one we published in 2017, and this is the way that I will show the results in all the evidence that I'm going to show you now. To begin with, looking at the effect of the intervention on the parental behavior with the child in the dyad. And here you see a chart. This is time along the bottom of the graph. This is the period of therapy here. And this is the follow-up period here. And the treatment as usual group who didn't have the intervention are along this dotted line. And this line is the group who had the intervention. And what you'll see is that the intervention produces, by the end of it, a very big effect to improve the parental understanding and appropriate synchronous response to child communication, social behaviors. And that this change in what we call synchrony and non-directiveness is the other term, is sustained then after the end of therapy for another year or two, and then it seems to sort of fall away a bit until we test the children at 3 years old. But what we look at in these graphs is the cumulative effect of the therapy by looking at the area between the treated group and the non-treated group over time. And we look at this area over time as a measure of the cumulative effect in development of the therapy, even after the therapy is finished. And when we look at this area, it's very significant. So this is a significant developmental change that we've made that lasts after the end of therapy. Then when we look at the baby, the infant's reaction with the parent in the dyad, you'll see you get a characteristic effect where there is a small effect at the end of therapy. It's what we call a lag effect, but that effect then builds over the years following the therapy and is sustained until 3 years when we measure at follow-up. It's not a massive change, but over time, it's cumulative. It makes a difference over time. And when we measure this area between the curves, it's highly significant to show that we are making a change in the autism trajectory over this time, which has a lag from the parent change, but it's sustained longer. Then our key outcome is whether we can change the child's behavior outside the family with another person in another setting so that they've generalized what they learned in the family out into the real world or the world outside the family. And here we use the standard measure of autism symptoms, AOC and ADOS, to look at the autistic phenotype, the autistic behaviors that define our condition over time. And here the line of the treated group goes down because this is less severe. This is the end of therapy. And what you'll show is that this is done with an independent researcher who is blinded to whether the baby has had the therapy or not. So this is an independent assessment which is rigorous within the trial. And we show here that the treated group show a reduction in the severity of autism symptoms across the board, and I'll come back to this idea. And this reduction in severity is continued, sustained over the years following the therapy, and then it seems to fall off a bit by the time we do the follow-up at 3 years of age. But again, when we look at the area between the curves, this is highly significant. So we have made a change in terms of the reduction of autism symptoms over time continuing in development after the therapy. So our second replication trial was done on a bigger group of infants in Australia, and these were infants who were identified in the community as having early differences in their development, early stage of an autism or neurodivergent trajectory. And they were identified about 1 year of age. And we had over 100 children in this trial, and we followed them through, just like the previous trial, we followed them through until 3 years of age. Again, the intervention was exactly the same, 5 months, followed up after therapy. And the thing to show you here is this is the same graph on the autism symptom outcomes from this Australian replication trial. And what you'll see is we get exactly the same effect in this trial as we did in the last one. That at the end of therapy here, the autism symptoms have reduced by a certain amount, and this reduction continues after the end of therapy over the next couple of years until we look at the children at 3 years of age. And that this area between the curve, again, is highly significant. So this trial shows a replication of this alteration in autism trajectory over time. But in this trial, we did something additional, which was at the age of 3, we had independent clinicians who didn't know whether the infants had been treated or not, to do an independent clinical best estimate diagnosis of autism diagnostic status using standard measures at 3 years of age and a consensus classification. And what we found when these clinicians did this was that the treated group of babies had a 2/3 reduction in developing an autistic diagnosis compared to the non-treated group. And so in the treated group, about 7% of the children who we treated developed autism, and in the non-treated group, it was over 20%. And this is a highly significant result. It's important to say that the children who did not reach an autism diagnostic threshold still had developmental differences. They just didn't reach an autism classification. They had other forms of developmental difficulty. What we call the number needed to treat to produce a reduction in this autism diagnosis was 7, or slightly over 7, which means we need to do 7 of these interventions to reduce one autism classification. And in terms of intervention science, this is a very strong result for an intervention to have that kind of effect on an outcome. So this outcome that we published last year received a lot of attention and was one of the most cited intervention science publications of the year. And it created some controversy, and I want to just address that a little bit here. So it's important to stress that the kind of intervention we do in this model is very different to the traditional model of behavior modification of autistic behaviors towards so-called normal behaviors, which has been traditional in the autism field. This is not a behavior modification intervention done with the child using behavioral theory. This is a transactional, interactional, developmental model working with parents in the dyad, as I've described. Our aim is to value and support neurodivergence, to understand it, to respond to it well, and to help these neurodivergent babies feel accepted, understood, valued, and responded to. And we know from developmental theory that that will then produce positive outcomes. And that's what we see in these neurodivergent babies. They respond just like neurotypical babies do to this form of care. So this is a way of giving support to neurodivergence, not trying to eradicate it. And we have to help the autistic community who are suspicious of intervention for this reason, understand that this is a care support, not a way of getting rid of autism. But the paradox is that in providing care of this type, we actually improve autistic social outcomes and improve social communication and improve well-being in a way that means that the classic way we measure autistic symptoms is reduced. This is a paradox which we have to address in the way that we understand how to define autism and how to measure it. But for the children, it is improving their social interaction, their social engagement, their well-being, and their happiness. And this is measured in our trial outcomes by a reduction in the ADOS. So as we've tried to explain this to the autistic community and to professionals, I think that people have understood that this is not a care support to be worried about. This is just valuing neurodivergence and making the best thing that we can from this form of developmental difference. So let me then turn now to the PACT intervention, which is the intervention that we developed first, actually, for children who have already had a diagnosis. So this is slightly later in development. It's a longer intervention where we work for 6 to 12 months with the autistic child, but it has exactly the same principle. We work with the parents, not the child, to improve their interaction, and we look for this generalization. And we use video feedback in the same way. It's based on the same principle that autistic communication can be difficult for adults to understand and empathize with. And what we need to do then is to help the parents really understand the nature of the communication and attend to the child. This relates to what's being called the double empathy problem, where the problem for the neurodivergent child is just as much that the environment does not understand them, as well as that they find it more difficult to understand the environment. And what we work with here is to improve the environment around the child to make it more understanding. So I'll just give you an example of the PACT intervention. Here is at baseline a child who has hold on. Okay, I can't play that, don't worry. So this is just to show that we can make a difference to the child's interaction in this kind of intervention, just like we do with the iBasis. I'll see if I can play this one. No. So not to worry about those videos, but it's to show that we can improve the interaction between the child and the parent. It doesn't magically make autism go away, but it makes a neurodivergent child much more engaged with their parent. So
The PACT intervention, we have made many publications now over the years. The most important publications have been these two outcome publications from our primary large trial in the UK, published in The Lancet in 2010 and 2016. And the 2016 paper demonstrated our follow-up results into middle childhood. So this is to give you the evidence from that long follow-up of the PACT intervention, which was of 152 children. So it's one of the largest randomized trials that's ever been done in early autism, or autism at all. And we had a 1-year intervention here to this point. And then we had a 6-year follow-up of these children. So these were preschool children before 5. And we then followed them up for 6 years into middle childhood. The average age of the children here at follow-up was 10.5 years. This is the only time in autism science, intervention science, that a follow-up of this length has been done, preserving the randomized groups. So when we look at the children here at 10.5 years, the assessors, we preserve randomization. The assessors don't know which group the child was in, whether they were treated or non-treated, and they rate the child using blinded measures. The blue line here is the children who received normal care, which could have been anything that they were normally getting. The red line is the children that received ordinary care, but in addition, they received a PACT intervention. And this first slide shows you the effect on the parents, the parental responsiveness and synchrony. And you'll see that by the end of therapy, we get a very large treatment effect to improve the parental synchronous response with the child. And that this very large treatment effect over time gradually disappears, so that when we look here, there's no difference between the groups. But if, just like I showed you in the previous slides, you look at the area between the curves here over time, this is a highly significant effect of treatment on ongoing parental responsiveness to their child. And there may be measurement issues here which mean that it's that you get this reduction. Here's the child responsiveness to the parent. And what you see is pretty similar to what we see with the babies. So you get an effect, it's not as big, but you get an effect during the treatment period with the child, so that the child is more engaging and communicative with the parent. And the important thing to note is that this effect during the treatment then sustains itself all the way through until the follow-up. So this is a treatment effect preserved over 6 years after the end of therapy. And this area between curves is highly significant. So here's a developmental intervention that makes a long-term difference even after the therapy's stopped. And then our key outcome, just as before, is the ADOS, which is the child's generalization of change away from out of the family into everyday life with strangers. How has this affected their capacity to interact with new interactions? And here you'll see that the PACT treated group have a reduced severity of autism symptoms, reduced extent of autism symptoms at endpoint, and that reduction is preserved all the way through until we get still a significant effect on the reduced autism severity right through to 10.5 years. And this, again, the area between the curves is highly significant. This is the first intervention at all in autism that's been able to show this kind of long-term effect based on a developmental model. And it's the basis on which we think we can make a difference to autistic and developmental trajectories using this kind of approach working with families. It's not just found in the researcher outcomes, but also when we ask parents how their children are doing at these different stages, and when we ask teachers about how the child is doing in school, we also get effects that support that this has happened. So the parents also report improvements, and the teachers also report improvements in the children, read downstream here. So this is an extraordinary result, really, for a developmental intervention for an autistic trajectory. So let me just summarize the evidence here then for the 3 trials where we've been able to show this long-term developmental effect. The I-BASIS here, the replication of the I-BASIS, and then the PACT. And you'll see what is so interesting is that the pattern of change here in the ADOS is exactly the same, really, in each of these trials. We're getting a very similar effect with these different groups in a different culture at a different time in development. And that gives me a lot of confidence that this kind of approach really is doing something generalizing in development across a lot of different samples. These are replicated science effects. We've also done studies to show how this works, not just that it works, but what is the mechanism by which this kind of intervention works so well. And our mediation studies show what we actually expected from the theory of the intervention, which is that when we look here in the dyad of the child's communication with the parent, which is the first thing that we shift, we improve the child's communication with the parent and engagement. That improvement in the trials, and we've got 2 trials where we've replicated this, actually, sorry, 3 trials where we've replicated this, but this improvement is mediated by the improvement with the parent. So we show that it is actually the change the parent makes that makes this difference. And you can show that causally when you do these randomized trials. So we're showing this is a causal effect. It's not just a chance association. If you change this parental response, you get this reaction. Most importantly, we show that it is this change of the child's learning within the relationship that is the thing that makes the difference at the end point to the child's interaction with another person. In other words, the child is here generalizing the learning that they've made in the dyad with the parent into another context. It's often been assumed that autistic children find it difficult to generalize acquired skills. Here we show that the child is generalizing these acquired skills into different contexts. Even more interesting than that is that when we look at the follow-up results, we see that it is this change during therapy in the improved child engagement with the parent, it's this change that also is responsible for this continuing improvement here. So that the change here is having a long-term developmental effect on developmental outcomes. And the important developmental understanding from these scientific results demonstrates the importance of improved social engagement for the child with the parent in this early stage. This is really worth doing because it has a long-term effect on developmental outcomes for the child. And that is really the justification for this form of early intervention in the mechanics of early development with an autistic or neurodivergent trajectory. That if we can improve this trajectory early on in terms of the child's social confidence, engagement, and competency, then that has big long-term effects on their well-being and functioning later. So with that evidence, how should we organize autistic services for neurodivergent and autistic children? And this is my proposal for a really radical rethinking of how we organize services, to stop doing a lot of what we're doing and start doing a lot of what the evidence shows us that we should be doing. So this is the model that I published with colleagues earlier this year, based on the work that we've been doing and this evidence that I've showed you, for how we could organize developmental services to support neurodivergence and early autism. It's got these developmentally phased sequences. It begins pre-diagnostic with early surveillance and picking up early neurodivergence, a neurodifference that may be of concern because it predicts an autistic trajectory, and working early on with those early neurodivergence in the way I've described. We then want to go on and support families around the diagnostic period. I'm not talking about this work, which we're trialing at the moment, but it's an important part of the pathway. And then after diagnosis, we want to work with the families to improve their confidence, the parental skills, their resilience, and their capacity to look after their child and improve the child's outcomes and well-being. After we've done this initial work, then we've got long-term follow-up work to do, because autism, of course, is enduring. And when the child goes into the community, into schools, and starts to live their life outside the family, of course, often new problems occur. Autistic children are vulnerable to mental health, other mental health and difficulty problems. So there's a sequence of support here, which assumes that if we get these pieces in place early, then these problems will be less. But we have to work with this first off before we work with this. So this is to improve then, first off, family resilience and competency and child adaptation developmentally. And then after that, to have services that can support other comorbid problems as they may arise later in development. I've shown you that the iBasis intervention is very well adapted to work here in this space. We also have new surveillance instruments, particularly this instrument called the SACS, which was developed in Australia, that we work with, that proves very effective in the early identification of neurodifference, predicting autistic trajectories. So we can combine surveillance and identification with this early support with an iBasis intervention to improve early adaptation and improve outcomes, as I've showed you. Then after diagnosis, we can put in an intervention like PACT, which I've shown you the evidence makes a difference to child's social competency, engagement, social communication, and well-being, which is sustained in development. And at the moment, PACT is the only intervention in the field that has shown those kind of long-term effects. There is one other intervention that you may know called JASPER from the US that also has, it works a little bit like PACT, but it's a more behavioral intervention, but It has shown effects particularly on language outcomes, improving language, and it's also got some evidence for long-term effects on language, which are useful and important. And so JASPER is another model that could be put in here to have the same kind of effect. But this is what the evidence tells us will be most useful at this time. So what do we need for a health service organization to make this work? Well, we need this integrated detection care support early on. So we have to organize our services to do this early on in childhood from the first year onwards. And then we need to have integrated support systems that can follow children through development and support them with key working. And then we need to have specialist services to look after comorbidity. I did have another slide to show that here, these new interventions that we need to have to help, for instance, comorbidities like anxiety, like depression, like behavioral challenges, like obsessive compulsive problems, that these, what we think of as comorbidities and mental health difficulties in autism, what we need for those is interventions that are specifically adapted to autistic development. And at the moment, we don't have enough of those. For instance, in anxiety, we have adapted CBT that has been shown to have an effect for children who are quite verbal and later in development. But we don't have any good evidence for early anxiety interventions at the moment, although I know you're going to be hearing later this morning about one that is in process, the CUES. In depression, we have the same problem. We don't have well-adapted interventions for depression. And for behavioral challenges, we do have some well-adapted, more behavioral interventions, actually, which have been published. But all in all, there is a lot of work to do here to develop specific interventions that show effect in the autistic community and are properly adapted to them. So,
Jonathan, I'm sorry, but we have only 5 minutes more for the speech.
Yes, just finishing now. Thank you.
Okay.
So this is just to say that we are testing this kind of pathway in the UK at the moment to see how we can implement this in everyday practice. And we are in the middle of doing this to see if really key everyday services can make a difference. So I'll have the results of that in about a year or two. So that's the end of my talk. I thank you very much for your attention, and I hope that the technical difficulties did not interfere with your understanding of the presentation. Here are my wonderful colleagues who worked on the iBasis, and here are my wonderful colleagues who worked with me on the PACT. And here is a slide for I'll just keep up. So if you've got any questions or you would like to get more information, then please contact us and we'd be very happy to work with you. So I'll stop there and see if there are any questions. Thank you very much.
Okay. Thank you. Thank you very much for your interesting speech and amazing work and projects that you do. I'm afraid we have no time for questions, but after lunch, we have some time for questions. Okay, Jonathan? Thank you very much.
Fine. I'll be happy to join you after lunch and we can talk in more detail about the presentation.
Okay, thank you very much. Take care.
Thank you.
See you later.
Okay.